We're going to talk about agent case studies today. So this has actually been really fun for me because we do a lot of ISR work at our hospital. Brooke is one of our techs back there. And so she suffers through these with us, like a lot of us suffer getting through these cases because they're really, really difficult. And so agent gives us kind of an option to treat this patient population that's really been suffering. And so we won't go through the data, which is kind of already covered, but we're just going to show a couple cases kind of demonstrating the agent algorithm and how we kind of approach these cases. And so I'm going to show two cases. And so this is the first one. This is a really nice woman, really unfortunate, had end-stage renal disease from something called IgA nephropathy when she was young, had a renal transplant that failed, is back on dialysis, had really malignant coronary disease in that setting, was actually getting worked up for another renal transplant, had terrible coronary disease and actually underwent a bypass. And in 2021, had a lima to the LAD and a rema to the circumflex. When she was coming in for evaluation for her renal transplant, she was complaining of angina, so they recathed her and found out that she had a failed bypass altogether. And so she actually underwent high-risk PCI in 2023 and got a DK crush to the left main trunk, LAD and circumflex, but then came back a short time later, even before a renal transplant, having her angina. And so got recath. And at that time, her EF had dropped from normal to 35%, and she had moderate MR. And so these were her diagnostic angiograms. And so really unfortunate, really ugly, unprotected left main trunk disease with failed bypasses, to both vessels with a low EF, and just really needs to get a renal transplant and actually get revascularized for symptoms. And so that's what we were looking at. That's what was sent to me. And I had the reports for the PCI, and so we brought her in. She was actually from Memphis, so I met her the day because I had done a video visit with her. And so she came in. And so with the low EF, we actually did a protected case with Impella and a 7 French system using a single axis technique. And this is our kind of setup shot. And actually was worse even than her previous one, even in a couple months in her angina had progressed almost where she was having it at rest. And so we're just going to do each of these cases with the agent algorithm, which I know you've seen. And really, I think the key of the algorithm is the balloon is really the most important part, but it's the easiest part and it's the final part. And so the other steps are what's really all of the work of the case. And you really have to be very meticulous. You cannot do ISR work without imaging. And I think that's the fundamental part of the algorithm, okay? And so this is the algorithm. It's simple. And the nice thing about an algorithm is you're taking complex stuff and trying to boil it down into discrete steps that you repeat so that it becomes a lot more simple than the complex kind of problem you're dealing with. And so the idea is to define the mechanism with imaging. And then once you know the mechanism, then you know how to treat it. And then after you treat it, reassess with imaging to make sure you treat it appropriately. And at that point, you treat with agent. So agent's just kind of, we call it the final coat of paint after all of the work has been done. And so, and then just taking a final picture and then, getting out of Dodge. And so this is actually what I use a lot of stent boost because this is actually the best way for me to see stent fracture. IVUS and OCT are good, but for stent fracture, we're actually looking at stent level, kind of strut level kind of detail. Stent boost works really well. And so all my stent ISR cases, I do a stent boost picture. And what you can see here, and I hope it comes through okay, is it actually wasn't what it was billed. It was billed as a DK crush, which was a stent from the circumflex into the main and crushed with an LED stent into the main. And you can see, actually, there's geographic myths. And so I know right then I'm actually dealing with a completely different problem, actually a pretty good explanation of why I have stent failure. So I know that before I start imaging, but then the imaging really helps even more. And so these are our pre-imaging kind of pictures. And you can see these are the pullbacks from the circumflex into the main. And so you can see as we come back into the main, you can see circumferential calcium at the ostium of the circumflex. It hadn't been treated completely over 270 degrees. And then this is actually a really important picture. And I didn't even catch this, the tech caught this initially. And so what you can see is actually the left main trunk is undersized. And I've actually wired, right, the stent is here. So I've actually wired under the stent and then back through the stent strut. And without imaging, I would have put a balloon in there and crushed that. So I would have created just a total metal mess in the main, right? So these images are really, really important. You got to take all of the detail, pay really close attention to them. And so I know right now I need to treat circumferential calcium, right? I've identified that problem. I need to rewire this where I'm actually in the stent and post-dilate this stent and then figure out how I'm going to treat the bifurcation. And so you can kind of see that. You can see that just the circle as we pull back into the ostium of the main, a really undersized stent, and I'm completely out of it. And then this is the picture from the AD. And this is a little more straightforward ISR. You have an underexpanded stent coming back into the ostium with neointimal hyperplasia. And you can see that coming back into the main there really nicely. These are the problems, from our initial assessment, that the mechanism is different than I actually even thought. So we have to reshift our plan. The initial wiring of the stent passed outside, so I've got to fix that. And then you have underexpansion of the proximal LAD stent that I'm going to have to fix. And then I've got this uncovered ostial circumflex with over 270 degrees of calcification. And then the biggest problem is I don't want to put a lot more metal in somebody that's already shown they're really prone to restenosis, right? So I'm going to try to figure out a way I can minimize metal, but treat all of these problems. And so I'll just kind of show you what we did. So the wiring of the left main was just taking some patience and making sure that I wired through, and then we could confirm that with IVUS. Under expansion of the proximal LAD stent was pretty straightforward. High pressure post-dilatation with a non-compliant balloon, and that responded really nicely. We treated the circumferential calcium and the circumflex with shockwave, and then confirmed with IVUS that we had stent calcium fracture and full expansion of our pre-dilatation balloon. And then this gets into the problem, and this is where AGENT was really, really helpful in this case. So I know I need to cover this ostium of the circumflex. And what I'll usually do in the left main is either a culotte or what's called a DK crush, right? And so here what we did, I'll just kind of show you actually just a couple pictures as we walk through. This is the pullback from the ostium of the circ, and you can see as we come in, just in 1 second, you'll see we have kind of the fractures and kind of the expansion of the circumflex. And so what we did was a DK crush. But normally with a DK crush, you're putting a stent back from the circumflex into the main, crushing it, putting another stent from the main into the LAD, recrossing everything. And so I already have a stent from the main into the AD. Where I'm really missing any kind of treatment was the ostium of the circ. And so what I did was a DK crush, but I didn't need to use the stent layer stent in the main because I retreated it, reprepped it. It was already there, and then I put drug down with AGENT. Does that make sense? And so you can see that here. You can see we're putting the circumflex stent back into the main. We crush it, recross, just like we're doing a DK crush. But instead of putting the stent into the main, into the LAD, it's already there. And so at that point, we just use AGENT. So these are just actually our prep pictures real quick showing our LAD coming into the main. You can see full expansion of the stent. It rarely ever gets this good. It's so nice, actually. And the circumflex, the same thing. We had full expansion, but, it would have been a total metal mess if I would have missed, the fact that I was outside the stent or if I didn't prep the ostium of the circ. And so after that, this is what we're looking at. And instead of putting more metal into the AD, we just prepped that and then put AGENT there. And so after all of that, these were our final pictures. And she did great, actually. She's still doing great. So a couple months out, actually back on the renal transplant list, she had pretty malignant restenosis. So I'm actually planning on doing a surveillance cath in 6 months. So we'll see. And so again, imaging is paramount to determine the mechanism of ISR. And then different modalities of imaging can kind of provide complementary information. Now, sometimes you get too much artifact from calcium. There's other imaging modalities. IVUS is the easiest, it's the simplest, and it's the easy way to kind of keep checking, right? So here, I knew I was outside the stent. I knew I had untreated calcium. I knew I had neointimal hyperplasia. And then I could keep checking here because this is going to be a big case where I'm going to have to go back in, and I can do that a bunch of times. And so IVUS and stent boost here was used to determine the mechanism of the lesion failure. And then we used AGENT in conjunction with the DES to recreate the DK crush. And then we avoided more layer, so metal in. So any questions with that case? Oh, good. And so this is the second case. call this the home run case. This is where I knew agent worked. Now, some of you have seen it. We talked about it. You wanted to see it, so you get to see it. And there are times when you're taking care of medicine, like patients, and you're using new technology, and you have these aha moments. And so that was the best part of this. This was where we were in the agent trial. So this is an agent patient. And when he came back with the problem that we're going to talk about, that was the aha moment, okay? And so again, we'll just look at the algorithm, same kind of steps. And so define the mechanism with imaging, lesion preparation, reassess, and then treat. And so this is what we're dealing with. So this is really bad. This is a bad problem. Like before I put dye in there, I mean, this is a bad problem. This is going to be just a total nightmare of a case. You put on the boots and you're just going to have to get through it. And I mean, some of these are the hardest, we do a lot of CTO work. Some of these are the hardest cases we do. And so it's really, really important, I think, when we're treating these types of patients that you go through this meticulously, all of the steps, imaging, figure out what's going on. Because if you put agent on a suboptimal result, it's not going to work. So if you use a drug balloon on crappy angioplasty, you're going to get a crappy result. So I was like, I looked at this and then I was like, I don't even know if I want to put him in agent at that time because I was like, what if he gets agent? This guy's probably going to come back. I was like, he's got like 3 or 4 layers of stent here. I'm like, if he gets randomized to agent, am I going to screw up the whole trial? I was like, so I was very nervous about it. So previous AVR, 1998, he's had multiple stents. We know at least 3 or 4 in that one area. And not only does he have ISR, but he's got an underexpanded stent on top of old ISR. So he's got forward prep and then more stents. And so he's got an hourglass just sitting there. And this is the guy that comes back and he says, my ISR is back. Like when he comes to clinic, he's like, it's back. He's quiet, never cries wolf. He's like 100% predictive. It's back. And so that's what he got sent over from Memphis specifically for agents. So this is kind of what we're dealing with. That's our pre-look. This is what I call the crappy IVUS. So everybody loves that because it's the non-HD IVUS. And here you've got so much stent. All you can see is you've got a lot of stent. But you can still get really important information about it. When we kind of step through it, you can see we got an MLD of under like 1.5 millimeters. The IVUS barely would go through it, just would kind of sit on it and pop through. And so we've got a big problem. I mean, you can see, you can count at least 3 layers, even though it's the crappy IVUS. And we're pretty sure there was even more than that there. And so we had just got Shockwave on the shelf, and this was going to be, I was like, I know exactly how I'm going to treat this. I'm going to use Shockwave because that's going to be better than anything we've ever had. And these are our Shockwave pulses. The thing just sits there. It doesn't budge. At that point, we got out laser. So this is with a 0.9 laser. You see, I've already kind of thrown in the towel because I've gone from radial to femoral. It takes a lot for me to do that. But I started wanting to use bigger devices. And so I've gone, this is 0.9 laser, putting contrast in to try to get kinetic energy to try to break up whatever's behind the stent so I can do it. That didn't work. I pulled out a 1.4 laser. That didn't work. And so then I got a 2.15 burr, the biggest burr I've used since I've been out, right? I'm usually pretty conservative with roto. I mean, I do a roto, but it's like, well, we're going to try to ablate the stent. We're going to turn this thing up to 225,000 and go in, and so and it just gets stuck. And I'm like, I mean, this is like the worst kind of feeling you can ever have. I mean, hearing that noise, you just got yourself in a lot of trouble. I'm like, do I call the surgeons? What do I do? And at the end of the day, you just got to kind of pull it out. So that's what we did. And, the guide sucked all the way down, but it came out in one piece, so like, okay, take a breath. We're okay still. What you can actually see is the stent now has started to change, though. It definitely is mechanically changed. So at that point, I came back with an angiosculpt balloon. To use it as a really non-compliant balloon. So this is a 4.0 angiosculpt, cranking it up to the Boston Scientific on the indiflator, and it ruptures all the way back into the main. So I actually thought maybe I'd, dissected back, but fortunately, everything was okay. So you could see it rupture there. That was another one of those, oh crap moments. And so then come back with an NC, and you can actually see we're starting to gain some here, right? It's better. It's not perfect, but it's better. And at that point, we take a picture, and this is what it looks like. And I'm like, agent is under 30%. And I'm still like, well, after what I just did, I'm like, do I put this guy in agent? Because if he gets agent, again, I'm screwed up the entire, I screwed up the entire trial. But I actually called in one of my partners. I was like, do you think it's 30%? We actually did QCA. We never do QCA. And it was under 30%. So I felt for the integrity of the study, we were going to randomize, and I would hope he would get balloon. And what does he get? He gets agent. So you can see our IVUS pictures. Again, we're over 3. It's better. It's not perfect. There's still a waste there, but a pretty big gain. And so I was pretty happy with that. And so at that point, we treated with agent. So there's our agent balloon. You can see the stent definitely better than it was. And you can kind of see where the agent balloon markers are. And after doing that, 13 months, so he luckily missed the primary endpoint, right? Comes back to clinic, and he's like, my angina is back. And I'm like, all right, I know exactly what's happened here, right? He's failed. He's got ISR. And so he comes in, and so we take him to the lab. This was our final picture. You can see where agent is, and this was the picture. So what's he got? Geographic miss, right? Right. Agent's here. It looks great. But where my guide got sucked down, where my balloon burst, where I didn't treat with drug balloon, where I had trauma to the stent, what happened? He got ISR. And I was like, aha, it worked. I was like, that's pretty cool, right? And so we brought him in, and he got a 4.0 POBA with a really nice result, right? And he had 2 layers of stent there. So that's how I treated him, with POBA, because I didn't have agent. Right? But it doesn't stop there then, right? So 19 months from agent, 8 months from my POBA, he's on vacation down in Florida. He actually gets a non-STEMI, comes in with chest pain, active chest pain, goes to the lab. Remember, this was our agent picture, and so they took him to the lab. What do you think he has? Agent site's perfect, right? What's the restenosis? It's my POBA site. And this is why ISR is such a big problem. These people don't typically come in stable. A good portion, 20, 30% actually come in unstable. So, if we're not treating ISR, we got to avoid it to begin with. Then we don't even have the problem. So actually we get into the whole discussion of let's stent the right way the first time. Image guidance, let's make it right if it works. But when we start having a problem, we're compounding the problem by putting in more stents, and then people come in like this. And so he's down in Florida. They don't have anything other, and this is exactly what I would have done. And so he got treated. You can see another couple pictures there. And so he got treated with another stent. And luckily, he's still doing okay right now. I just saw him not too long ago. And he was pretty excited. We've talked through this whole thing about his drug balloon site works. He's really happy, he participated in the trial. But this was where it really illustrated some nice things, right? It illustrates you got to figure out the problem. It would have never been able to do that any other way. You've got to have a lot of different modalities to treat the problem, make sure you're treating it right. And then at that point, you treat with agent. And so we got a nice result there. And so I'll stop there.